Hi, I'm Susan Nancarrow. I'm the founder of Healthwork International and started the Allied Health Academy. And look, I guess the background to why we've done this is recognition that there was largely a lack of recognition of the allied health workforce, a huge and diverse workforce, and we lacked data on it. And so one of the things that we did to try to achieve that was start a company called Healthwork Solutions, where we have looked at trying to collect data on the workforce, and in doing so, kind of accidentally become experts in the unregulated workforce. So that's the basis of my presentation today. Just letting you know that the session is recorded. We'll only start the recording from when I start talking, and we've already introduced ourselves, so I don't think we need to pop anything to the chat. What we'll do with the recording is edit it and upload it into the Allied Health Academy platform so that people that can't attend have access to it. And there's hopefully opportunities for a quick Q&A after the session. I'd like to start by acknowledging the traditional owners of the land from which I'm meeting, which is the Arakwal people from the Bundjalung Nation, and acknowledge elders past and present. And I'd also invite you to acknowledge the peoples from the land on which you're joining us today. So regulating the unregulated workforce, why does it matter? I was just saying to Jess at the start that we get approached by a number of different audiences for this kind of work. So I've sort of made this broad, a lot of learning from our experience with the allied health assistants, but I'm very happy. I've got a whole lot of content at the end, so I can really tailor this to answer specific questions. And I've got a fairly good idea of what the issues are for the perfusionists. And look, I know a lot of this will be familiar to you. The first thing I'll talk about is the purpose of regulation and the 4 types of regulation. And I won't go into that in much detail because I know you're familiar with it. Give some examples of the different types of regulation and the opportunities of risks and risk of the regulation, and also address some of the frequently asked questions. But I'm going to use our experience with AHANA to illustrate those. So look, really there are 7 reasons that we regulate the workforce. I'm going to just move this screen over. Public safety should be the first one, but what we've seen is regulation's been around for the professions for about 150 years, and essentially it has protected the professions first and foremost, and we're moving more and more towards public protection, but there are still some issues, I think, there about the tensions between public safety and professional recognition. Professional accountability, so establishing clear code of conduct and accountability. Standardising the workforce, so people understand who you are and what it is that you do. Consumer trust, legal and ethical compliance. Health system efficiency, and this is something that we haven't done very well in allied health. We don't have a lot of data, and I'll explain why in a moment. And I think the other thing that we don't think about a lot in terms of regulation is workforce mobility, the ability to have standards that get recognised so people can move from one organisation to the other, one state to another, or even internationally. You're probably familiar with these 4 types of regulation: voluntary certification, co-regulation, negative licensing, and statutory regulation. So voluntary certification is where a group of people get together with a common craft area, and they agree to a certain set of standards. And we see quite a voluntary self-certification in the unregulated workforce. Masseurs, hypnotherapists. I think hypnotherapists have about 4 different professional bodies that they use as their self-regulation model. The next model is co-regulation, and this is a step up from voluntary certification, and this is what you have as perfusionists and what we see with NASRIP and actually the majority of the allied health workforce, which is where those professions have agreed with government or funders that you are the gatekeepers effectively for a set of rules. And the example that I use, and that's a similar example to perfusionist, is podorthists. Podorthists are orthopaedic footwear manufacturers. They're a very old profession, but they've only recently, in the last 50 years, organised into a new profession. In Australia, there are about 70 of them. They've set up their own training pathway, and initially that was through importing training from the US. So they set up a voluntary certification scheme so that the Podorthics Association members had to have completed their certified training. But they've achieved co-regulation by convincing government, and Australia, it's the NDIS and other funders of disability services who provide orthopaedic grade footwear, that only members of that association are eligible and qualified to provide those services. So that's what we call professional closure. And the discussion that I had with you at the start, Jess, suggests that that's what you're after. So it's actually a very powerful model, and this is what we're really striving to achieve with AHANA. The other one is negative licensing, which basically is used for a lot of the unregulated workforce. It's not used widely in Australia, but it means that if the workers don't adhere to a code of conduct, they can be listed on a register of practitioners who are not safe to practice. So, for instance, the massage industry uses that in some states. And then statutory regulation or occupational licensing is the model that we're most familiar with. This is the APRA regulated professions, but in Australia only 16 professions are currently recognised under that code. So that's where we're currently at the moment. What I'm going to talk about mostly today is voluntary certification and co-regulation. This is an old list that I pulled together. I pulled it together about 3 or 4 years ago of the self-regulating professions, and I got the data from the professional associations, so the numbers aren't very accurate. For instance, the Australian Association of Social Workers, that was the number of members they had in about 2021. I believe there are about 30,000 social workers in Australia at the moment. But this just gives you a quick idea of the number of professions that are out there that are self-regulated. And our last presenter was Anita Hobson-Powell, the Chief Allied Health Officer, and she said that she represents around 60 professions, even though they're not all members of ARPA. So, and you can see a lot of them are quite small. Play therapists, 100 workers, infologists, around 100 workers. They've probably got more than that, but there are quite a lot. Actually got some of those duplicated. So why do we want to regulate the unregulated workforce? And I'm going to talk some of our example of regulating allied health assistants in Australia. So the problem that they had is common to a lot of the unregulated workforce, but more complex because they lacked a clear coherency. So first of all, people didn't know who the allied health assistants were, and they were poorly recognised. They weren't recognised nationally. They had no quality standards or minimum standards of entry, and we also see this in the disability support work. People could just go and set up an ABN and call themselves an allied health assistant or a disability support worker, but there was no way of understanding who they are or what they're doing. We talked about the mobility of roles. We spoke to a number of allied health assistants who had spent years, sometimes decades, working in a particular area. It might be, one example I'll give is a cast technician. So they were able to take casts off, but because there was no credentialing around that, they couldn't transfer that to another area quite easily. There's no verification of the qualifications, so there's no standardisation of the qualifications for this workforce at the moment. High levels of variation and large variations in job roles. So this was the problem that the actual clinicians themselves, the practitioners, were experiencing. From the employer perspective, same sorts of issues, but looking at it through a different lens. Where they worked in the public sector, we were seeing different awards and training models for every single jurisdiction, different funders, aged care, Veterans Affairs and so forth, although Veterans Affairs don't actually acknowledge allied health assistants. Professional associations, so up to 30 different professions recognising allied health assistants differently and often trying to work for multiple employers. The other thing that we're seeing is more and more of these workers moving outside the public sector where they've got established clinical governance and trying to work in the private sector, and so they're trying to set up their ABN and they don't have those clinical governance and accountability models. And we're seeing huge levels of confusion around what they can do, what's safe to delegate, who wears the risk if I delegate something to an allied health assistant or another care and support worker, and where's the insurance lie. And so that's a big risk and also a fairly big opportunity for allied health assistants. And again, the lack of training, consistency or quality assurance, which actually leads to a lot of inefficiency in those roles. It means that if I've spent 20 years working as an allied health assistant in rehabilitation, without any credentials from that and go into another setting, there's no way for the people I'm working with to know what I'm capable of. And so they tend to underutilise those roles. But what's also important, I think, at the system level is that the patients, customers or service users also don't understand what those people are capable of. So there's a branding issue. And I think one of the challenges we have with negative licensing, which is where you sort of get struck off if you don't meet the codes of practice, is that also stops you having that professional identity. So, this is where we get that tension between what's important for professional identity from the profession's perspective, but also in terms of the service users being able to recognise it. But specifically for allied health assistants, but not only them, there was a need to increase the capacity of those roles. So just identifying them, counting them and mobilising was important. And it's the issue for all of those unregulated workers. If they're not a member of their association, and often even if they are, we don't know who they are or where they are. So we've got, for 2/3 of the workforce, we don't actually have good numbers on them, which means that we can't plan for the workforce appropriately. So how can self-regulation address this? So what we saw with AHANA was that they had set up an initial professional association. What we have done is set up a voluntary self-certification model, and we're now moving towards self-regulation, where we're trying to get recognition for this group from government funders to support them. So what a self-regulation model does is provide a quality assured workforce. At the very least, they have to adhere to a code of conduct, mandatory professional development, and there's a register of workers so people can see who is a member. There are issues around professional registers in terms of protection of those workers. That is the current model at the moment. But it also provides that reassurance to employers that someone has met a hurdle for entry, and can also provide reassurance to public and the end users. So what does self-regulation look like? And I've just used the term care and support workforce to encompass all of the unregulated workforce, but a lot of the work we're doing at the moment is around allied health assistants, and we're also interested in the disability support workforce and aged care workers, but they have got some similarities and also some differences. I guess the first thing we've had to do is define who comes in. So what is the entry criteria? And that's been quite challenging because they don't have a standard set of qualifications. So we've had to recognise that this is a heterogeneous group. As I said, they don't have standard qualifications, but we need to incentivise and recognise people that do have qualifications. So that's a tension in recognising this workforce. We need to be able to enforce a code of conduct, ensure that they have met this minimum mandatory professional development, and maintain ongoing practice. So that also requires a register and capturing data. And members can also claim some kind of post-nominal, so people know that they're a member of some kind of club. So what are the benefits and risks? So the benefits are that self-regulation is actually owned by the workforce themselves, so they get to set the standards for entry. It's voluntary. At the moment, if you want to get to that Commonwealth level legislation, you have to get agreement from every state and territory, so it's quite a cumbersome process. It's quite quick. You can establish the entry criterion quite quick. Compared to statutory regulation, it's relatively low cost to enforce, although it's a lot more expensive than we realised, and I suspect fusionists, it's probably been quite expensive for you as well. But it also unites what has been a fairly heterogeneous workforce into a club, and that's also been a tension which I'll go onto in a moment. The challenge for this workforce, and we also know it's a challenge for other workforces, is it sets a hurdle for entry. So while people want entry into the club and to belong to the club, you've got to demonstrate that you've met certain criteria to get there. For the allied health assistants, we have needed up to 5 different sources of data for people to prove that. Their qualifications, history of practice, some places we don't actually do police checks, but references and so forth. Plus there's a cost to entry. And so when we're dealing with an unregulated workforce, and particularly a relatively low skilled in terms of lack of formal qualifications workforce, if we set the entry criteria too high, they'll go and get work in competing sectors. And we have seen this in the care and support workforce. If they're not paid well enough, they'll go and work in retail or other types of sectors. On the same side of that coin is that there aren't incentives for individual workers to join without some sort of funding mechanism. So we have worked with a number of different voluntary associations that want to go to self-certification or self-regulation, but without those drivers, like the one I raised with the podorthist, unless they can close the shop and say, we'll only get funding from NDIS, Medicare, aged care, if you're a member of this club, then there's no incentive for people to join. So we get this sort of swings and roundabout. If you don't have the club, you don't have the leverage to get the funding, but if you don't have the people if you don't have the leverage to get the funding, you don't have the incentives to get the club going, which has been an issue with AHANA. So how does self-regulation currently work? At the moment, people opt in. They don't get title protection, which does seem to be a sore point for those professions. It's voluntary, but there are strong incentives for people to have membership. And as I mentioned, they need to have that registration with their professional association or be eligible for it to have access to these funding models, or the employer model, which is the discussion that we were having earlier about fusionists. There's no access to workforce data. So we've done work with a number of self-regulating professions, and the only workforce data we can get is with the members of their profession. And so if they have this co-regulation model where you have to be a member of the association to get access to these funding models, then there's a strong incentive for people to join. And so we're seeing high rates of membership there. But if they don't have the co-regulation model, then there's not a lot of incentive for people to join. So ironically, we see higher rates of membership of the professional associations of the self-regulated professions because it gives them that access to funding, whereas the AHPRA-regulated professions, there's less incentive for them to join the professional association because their AHPRA regulation gives them that funding. And the profession sets and monitors their professional standards. I think I've already raised that. So one of the big problems that we've had with the care and support workforce is, unlike the NASRP registered professions where you've got at least a standard level EQF 7 or above entry criteria, this workforce is mostly certificate trained and sometimes they have no sort of training. So how do we put a protection around that group of workers when we don't have that training? So we need an entry criteria that recognises that there are people doing that job, but what is the entry criteria, but also how do we acknowledge their qualifications? So for AHANA, we've got 8 membership classes, 3 practising members and 5 non-practising membership classes. Sorry, that shouldn't be on automatic. What we've done within the 3 practising membership classes is the practising member provisional that recognises that anyone that is currently working as an allied health assistant can be a member. So they don't need to have any qualifications. As long as they're working as an allied health assistant, they're eligible for membership, and that gives them access to insurance. They have to adhere to the code of conduct and the other things that we've got. But we incentivise them if they've got training. So a practising member general is someone with a Cert 3 in allied health assistant or 450 hours or equivalent. And a practising member certified has a Cert 4 in allied health assistance and 450 hours, or that actually should be a diploma and 150 hours or equivalent. The point I'm trying to make here is that we have a club that lets everyone come into it, but we recognise higher levels of qualifications with different credentials. So what have we learnt from the introduction of AHANA? And I know perfusionists, you'll have had the same issues. First of all, for a self-regulating workforce, co-design of the association and with the association is essential. It can't be imposed, and it needs to have strong governance that includes members of that professional association, but you also need other skill sets. And I would say education and training, probably marketing, and an understanding of the health system is quite important. One of the issues that we've really struggled with AHANA, and we thought we'd overcome it, is this issue of professional identity. Because we don't have a single qualification like a Bachelor of Speech Pathology or a Master's in Perfusion or Physiotherapy for entry, we've had to put some boundaries around who's in and who's out. And we initially set that as a qualification in allied health assistance and or working under the delegation of an allied health professional. But we've had other occupational groups that want to come in under this model, for example, recreation and leisure workers, and we're also talking to some fitness professionals, but they don't have the same model of working under delegation. So while they fit our professional associationship model, we're having debates now about whether or not that's diluting the professional identity of allied health assistants. So that is an issue for this kind of workforce. The other question that comes up every time we go out to consultation is people wonder how we can have voluntary certification without having standardised training. And I think people get confused between scope of practice, and in Australia, scopes of practice are not regulated. There are some tasks that are regulated. I mean, in the health sphere, it's largely prescribing and some diagnostic tests and surgery, but no professions actually have regulated scopes of practice. So that's really important here. What we're saying is that people are adhering to a code of conduct. Entry into the profession for the other self-regulated professions tends to require a minimum standard which is achieved through qualifications, but we don't have that with this workforce. So that is a point of distinction, but we do recognise the training. I think that's quite important here. The other issue is responsibility, accountability, delegation and risk, and who's responsible when something goes wrong. And I actually think we just need to change this whole model of delegation. This is my opinion, and it's my opinion only. If someone is qualified to do a task, if they're credentialed to do it and they're working within appropriate clinical governance structures, then they should be expected to do those tasks wherever it's reasonable and appropriate, rather than expecting that task only to be given to them under delegation. And we've had a lot of debates around that and who gets to delegate. And I think if we solve that delegation issue, we'd be sorting out a lot of issues for the allied health assistants and this general unregulated workforce. The other confusion that comes up with the workforce that we're dealing with is if I'm a care and support worker, and I think it applies to any self-regulated professional, if I'm working outside a health system, if I've got my own ABN, if I'm working for myself, where does the clinical governance, the delegation, the accountability and the supervision come in? And is that a risk? And one of the things that we've really had to be clear to separate is that someone can still be a certified practicing member and be self-employed, but being a certified practicing member of the association requires them to adhere to that code of conduct. So they need to have supervision. They need to have, at this stage, have work delegated from an allied health professional, but they can do that within that employment model. And I think we really need to be careful to separate employment models from regulation and registration. And I think it's at this pointy end of the workforce that really gets confused, and I'm happy to talk about that if that's useful. Look, I might end in a moment because I know I'm over time. I think the real opportunities we've got here, particularly with this workforce, is actually to set this regulation framework for the unregulated workforce, but start to put some credentialing around the skills and tasks and recognise those to let them move up a career pathway. You have the technology now to let people have a digital passport. So, for instance, if someone has worked with people with autism or in a particular context for a long time, we should be able to credential that, recognise it, and set up some kind of transferability around that. If we could do that, we could also then start to collect the workforce data. I just want to go, but I also think we've got the opportunity then to create some stackable credentials to create a dual career pathway for people coming in at that base level. And I just want to show you a career pathway model that we've been working with a couple of other jurisdictions. What we've got here, and this is a grid that we can apply across every single, it actually could apply across every single health occupational group, but we've developed this for allied health professionals. We've got 4 areas of practice: clinical practice, research, education, leadership and management. And this is the capability levels, entry level, right up to consultant practitioner. Now, we could retrofit this to, so entry-level practitioner at this stage is degree level, but we could retrofit this to fit the care and support workforce as well. So you could have the AQF level 4 to 5 and 6. This is entry-level AQF 7. But there's opportunities, I think, with that kind of flexible credentialing pathway and skills passport to allow people to move up this career pathway without necessarily having a cognate area of practice like perfusion, speech pathology and physiotherapy. Look, I might stop there and open it up for questions, given that we're over time and I've got sort of some understanding of some of the issues that you'd like to talk about. And I've got some more information here if you need me to talk about some other things. So, yeah, any questions, comments, feedback, thoughts?
You've got Wendy on here too, who's the Secretary of the Board of Perfusion.
Hi, Wendy.
Hello. Hi.
This is your own private consultancy today.
Yeah, it almost is. Right. I've sent the link around to a lot of people too that unfortunately couldn't attend it, but hopefully they'll be able to watch back because, you know, there's so many layers to this. Like you say, there's just, you know, the completely unregulated and not even at sort of a self-regulation level in some professions to, you know, we're sort of, you know, where we are, we're co-regulated, I guess you'd say. And then it's like kind of saw in that triangle that you've got there, like navigating the next step and the next level. And I think that's where people, you know, you find it hard when you're transitioning from whatever level you're at to the next level. And that's where a lot of the challenges for any profession, no matter what level they're at, going for APRA, going for self-regulation, going for co-regulation, that all of these challenges and barriers are there, which is unique to each profession. But one of the consistent things that's there is you're always going to get people in your own profession that aren't ready for it or are pushing back and innately don't like change because it's been that way for so long and that's the way that it should live and die. So I guess, how do you navigate those challenges specifically around change in the landscape with changing time. Like, we're not going to be static and status quo for forever. So
you've raised a number of really important issues there. So, professions are like organisms. They like to evolve and they like to, I guess, take on higher and higher levels of recognition. And a lot of, I've run workforce surveys with thousands of people. And when we say, what's if you could solve one issue for your profession, what would it be? And the biggest issue that comes up for the self-regulated professions is we need to be recognised by AHPRA. And I don't necessarily think that is the pinnacle. If you've got professional closure, which means you're getting funding and recognition of your occupational group, then I actually think you've achieved what you need to achieve, probably for a lot less cost than AHPRA, and arguably risk, I don't know. But the point that you've made as well is, where does the resistance come from? And there's a really nice case study of operating department practitioners in the UK who had exactly your model. They then went for health and care professions council regulation. So they already had professional closure. They were recognised by the NHS. You had to be a member of their association to get a job as an operating department practitioner. What's actually happened now that they've moved into the Health and Care Professions Council, they've got a common award, and people are going, well, what's the difference between you and a nurse? So there's been a huge amount of blurred role boundaries. It's different here because our professional awards aren't so tied up with our regulation. But look, even with pediatric surgery, the biggest resistance to recognition of pediatric surgery has come from the podiatrist. So, yeah. You're on mute, Jess.
Sorry, there's always one. So I think a lot of people see regulation as bureaucracy as well, and sometimes unneeded or unhelpful layer of bureaucracy. And so, yeah, like you say, that AHPRA registration might not be it's not necessarily where every profession needs to be. I guess most people aim for that because that is the pinnacle. However, yeah, some more, and I think that's what you guys do really well, obviously, is just educate on other opportunities and other avenues that people can take to gain the critical things. It's recognition and awareness of the profession, ultimately for public safety and reducing risk generally for the people that we're serving. So getting that buy-in from the employers, from the hospitals, from the state health departments, and obviously federally to understand that as well. And just because you're not AHPRA registered doesn't mean that you shouldn't have professional closure or that you should fear your workforce not being responsible for that area or their, I guess you say scope of practice, but that area, recognition that AHPRA registration isn't the be all and end all, and you're not anybody until you're AHPRA registered.
If you look at the opposite of that, we get approached by small, I would call them emerging occupational groups. They're out there doing work and not particularly well organised. So, there might be 3 different competing professional associations representing the same groups. And that's, I think, where you run the risks, because you've got, one group saying, well, we're the peak body, and another group saying we're the peak body, and they've got competing philosophies around the type of work that they're doing. And that's partly because they're working outside a kind of mainstream science model as well. But that's probably the biggest risk to those occupational groups. It's the lack of it. Again, it comes back to your point. You've got 3 different philosophies fighting against each other, and what they should do is come together and say, we're a united whole. This is what we do, and this is how we do it. And they could structure their own profession around that, I think.
Susan, thanks so much for that presentation. It was really thorough. And I think you touched on a point that I was going to ask about, is your experience with professions with competing interests with other groups. So you've kind of touched on that. Has that been more with competing groups with allied health? Or has it been, say, competing with nurses or competing with medical that are completely separate groups? What's your experience been like?
So the groups that come to us are groups that are competing amongst themselves. So they've got literally 3 or 4 different professional associations representing small subgroups of the type of work they're doing. However, we're doing work in one particular jurisdiction where we heard an example of pharmacists actually blocking the scope of practice of speech pathologists, even though the work that the speech pathologist was doing was in their scope. So, look, we see a lot of, we see a lot of that tension. I mean, there's been some quite high-profile discussions about physiotherapy and exercise physiology, and they're not actually regulatory, because the scopes of practice aren't regulated. They're not actually regulatory issues. I would call them branding issues. We do this and you do that. I'm a podiatrist by background, and a lot of the biomechanical stuff that we do is also done by 5 different other occupational groups. It's just who has the market reach and credibility and funding, actually, importantly, to be able to deliver that role. So
yeah, I guess it does come down to, that credibility, that funding, and probably that's where we're a little bit heated waters with our competitor, who's emerging recently, stronger than before, and that's a medical competitor from the anaesthetic groups. So that makes it a little bit difficult. And you may know there's, Medicare item numbers and so forth that's unique in Australia, that's not seen international. So that makes it a little bit tricky.
That's such an important issue, because actually we see funding models in Australia stopping efficient scope of practice. I mean, it absolutely makes no sense to get, let's say, an anaesthetist to do your work. If you can do it, because that's kind of your core business, you can do it, presumably cheaper and better, because it's all you do.
And really well.
Yeah. But
Okay.
I think that's, the scope of practice review kind of brought this up with podiatric surgeons as well, and the review of podiatric surgery is probably worth looking at to see what happened there, because they said they should be Medicare funded, they should be in public hospitals, they've got the skills, they've got the training. It's just competing boundaries that stops that happening.
Okay.
Susan, I'll have a read of that, but out of interest, do you know off the top of your head, did they end up getting provider numbers and access to Medicare item numbers through that, or no?
No, that's, what happens with the scope of practice review is going to be interesting to see, I think.
Yeah.
Susan, sorry if I missed it, and my camera's on now. Sorry, I've moved spots. This could be something that I just missed in the course of it, but and it's a bit of a different track, but have you got any comments or thoughts around regulation and data collection in terms of workforce support and planning? Because this seems to be something that comes up. And I'm just interested in your thoughts.
Really, we started HealthWork Solutions to try to collect the data for the self-regulated professions that AHPRA is collecting for the nationally registered professions. So yes, we think that really is important, and the way to do that is to have a register of professions and sort of a minimum data set. We're so far from that. I mean, we've looked at lots of different angles. We've worked with professional associations to get the data that they collect and map that, and that's the best that we've got at the moment. So look, I think there are a number of issues here. Is first of all, who are they and where are they? And if they're not a member of their professional association, how do we get the information? And then are the professional associations collecting data that's useful? At the moment, just getting a postcode and a profession is a good start, and we can do some work with that. But I mean, if you take speech pathologists, for example, and we did a big project with them, a lot of them can work remotely. Music therapists as well. So you've got music therapists living in Hong Kong delivering services in Australia. So, what is the location of that worker, and does it matter if they're a remote worker? So yes, look, I think that is one of the biggest issues, because if you don't have the data, you can't do we don't do any workforce planning anyway for allied health, but it puts us really behind the 8 ball for that workforce.
And so in regard to that data, you were saying that you guys actually collect for the self-regulated professions. Yeah, okay. And what's the mechanism that supports that collection?
It's just registration. So when people register, so all we've got is the data on the members, which is all the self-regulated professions have anyway. But we think we've got a pretty good minimum data set, and we could advise the professions on what they should be collecting based on everything we've done. But there's no mechanism. We've tried working with different groups around this, but it's very hard. There's no funding. There's resistance to
sharing for whatever reasons.
Even though it's in everyone's interest.
Thank you.
Thank you.
Susan, on that data, is it worth capturing, say, from our point of view, or any profession's point of view, really, is it worth capturing that, like, workforce location, I guess you'd say, data for, you know, anyone who could be doing the job or the role of that person, whether they're qualified, they're not qualified, credentialed, not credentialed, if they're part of the self-regulated organisation, if they're not. So we've got, you know, we've got perfusionists that are certified. We've got very few that are clinical perfusionists that aren't certified. We've got overseas trained people that are working here that haven't gone through the overseas trained recognition pathway. We've got medical perfusionists. We've got perfusion technicians who help the medical perfusionists. In some case, they're clinical, like certified perfusionists that are helping the medical perfusionists for that case. So there's a couple of crossovers in the role of who's doing perfusion in that institution. And is it worth trying to, as much as we can, being there all different workforces, capturing that data to better inform us on, I guess, the state of play across the country, really?
That's a good question. I think there are two ways of looking at this. One is, in whose interest are we collecting the data? And I would start with the population need. You know, we've got a population that needs access to a service, perfusionists or whatever it is. Look at the distribution of population need for that workforce, and then look at the supply of that workforce. And I think what you've identified is the supply of the workforce, regardless of who is providing it. Then if you look at it from the profession perspective, so there's who is a member of our profession and who is eligible, and look at the workforce planning issues. So what's our training pathway and pipeline and so forth. What you would like is that the population need for perfusionists is the same as the population supply, and those people are members of your association and have your training. What you've identified is that there's probably a core group that are, and then there's a bunch of people around the outside who can do the job but aren't necessarily members of your association. And what do you want to do about them? And that's actually useful information for you to have as well. But if I go back to, I mean, we've tried to do this work around occupational therapy. You know, there's occupational therapy is largely, you know, they do 100 different things, but identifying the need for an occupational therapist is largely based on social determinants of health, which means that if you don't have an occupational therapist there, you can probably substitute for some other aspect, like a social worker for particular roles. And this is the case, musculoskeletal's probably got more substitution. If you don't have a physio, I know people using exercise physiologists, chiropractors, osteopaths, podiatrists. But if you've got that basic population need, then you can start to look at who that workforce is that could meet that need. And I think that is the basis of what would be good population planning.
That really speaks to the I guess the multidisciplinary team coming to the forefront in terms of primary health care and the planning. And yeah, I think it's just such it's got so many moving parts, that whole discussion, I suppose.
It does, yeah.
Finding out where actually people are and what they're doing is kind of the first step, but it's a bit hard to put your finger on it, isn't it?
Look, we've done it. We've got some mapping. I can send it to you after this. We've started it.
That would be
great. Proof of concept with podiatry. We've actually got the tools to do it. We just can't get anyone to fund it. So
okay.
Yeah.
Yeah, well, that'd be good. I can
hang
around.
I'll send that to you afterwards. Yeah, or I can send it to you. Yeah, I can show it. In fact, if anyone wants to see it, I can probably demonstrate afterwards, but realise that we're well over time as well.
Yeah, I think the mapping out of where everybody is and what their role is really important information, and being able to, you know, and that's where we can really formulate, okay, where's everyone going and what are our gaps and what do we need to do? So I don't know how you would feel about it, Jess, but how difficult do you think it would be to get that information from the non-clinical perfusionists? You're on mute again.
Sorry, for us, I think it's easier than some other professions because
not that many.
If you think about our workforce, there's not that many people, and like Renelle, for your context, there's only 200 of us in Australia, maybe, and we're primarily in cardiac surgery. So if you locate all the cardiac surgery sites, which isn't hard to do. Generally, they're in metro cities. There's a couple of more regional ones, and by regional, I mean like Newcastle. So and Geelong, which is like not regional, but there's only certain sites, and even those ones that we do know of that aren't staffed by clinical perfusionists, maybe medical or what have you, we know those sites. And so I think it's relatively easy. Obviously, we've got membership data and everything that we can go off and certification data, but mapping out those that aren't part of our, I guess you'd say, club, I don't think would be too difficult. Yeah.
I've just dropped our mapping tool into the...
Yeah, thank you.
And also we've written a paper on it. It's just a proof of concept in podiatry, but we can apply it to other occupational groups. We just didn't have permission to use it. So I can give you access to that if you don't have access to the journal, because I think it's closed access. But
Thanks, Susan.
Thank you.
Thanks, everyone. Any other questions or comments? We'll make this recording available anyway. Well, it was a lovely discussion with the small group, so thank you. All right.
Thank you.
Enjoy the rest of your week. Thanks,
Thank
everyone.
you.
Oh,
Thank you. Nice to meet you.
Bye.